So I am presenting 22-year-old married gentleman from the West Bengal, farmer by occupation, and presented with the chief complaint since patient complaint of left side testicular swelling since 1 year, abdominal swelling since 3 months, and low backache since 3 weeks. So history of present illness. Patient was apparently all right since 1 year back. Then he noticed left side testicular swelling, which was insidious in onset, which was non-progressive in the initial phase, but started increasing the size from last 3 months. Not associated with any pain, not associated with any trauma, not associated with any fever. Patient was evaluated at the local place for that swelling and was informed by treating physician suspected tumor. So underwent surgical procedure 2 months back. And patient had a history of abdominal swelling since 3 months.
Your voice is not very clear in this. Can you come a little bit closer to the mic and speak a little bit slowly so that?
Yes, sir. Yes, sir. So, sir, 22-year-old married gentleman from West Bengal, farmer by occupation, presented with the chief complaint left side testicular swelling since 1 year, abdominal swelling since 3 months, and low backache since 3 weeks. Patient was apparently all right since 1 year back. Then he noticed left side testicular swelling, which insidious in onset, which was non-progressive in nature initially, but started increasing in size from last 3 months. Not associated with any pain, not associated with any trauma, not associated with any fever. Patient was evaluated at the local place and had to inform suspected tumor by treating physician and underwent surgical procedure 2 months back. Patient had history of abdominal swelling since 3 months, which is left side of the abdomen. Incidentally, we noticed the swelling on the umbilical region when we touch his abdomen incidentally, and this is onset is insidious and gradually progressive in nature. So not associated with any pain, vomiting, constipation, and cramp. Not associated any fever, not associated with any weight loss or loss of appetite. Patient had a history of low backache since last 3 weeks, constant in nature, moderate to severe in intensity, non-radiating, localized, no diurnal variation, no worsening or relief after positional changes, and patient relief with the analgesic. And no history of any cough, shortness of breath, no history of any headache, no history of any previous tuberculosis, and with the contact with tuberculosis. And past history, there is no significant medical or surgical past history. Personal history mixed by diet, bladder bowel habits normal, deny any addiction, or no significant family history regarding medication. So, summarize my history. 22-year-old male with testicular swelling, which is underwent some surgical procedure with abdominal lump and low backache since 3 months. So move to general physical examination. Patient is oriented to tankless person at the time of examination with ECOG performance status is 2, comfortable on supine position during examination. Vitals, patient is febrile, pulse rate is 80 per minute, blood pressure is 10 by 80, febrile and respiratory rate is 22 per minute. No pallor, no icterus, no edema, and no palpable lymphadenopathy. No palpable supraclavicular lymph node. No bony tendon over prominence, no vertebral tenderness, or no evidence of gynecomastia on general physical examination. Move to the systemic examination. Oral cavity looks normal, no stent teeth, and no visual any growth or ulceration. Neck is no palpable neck node, no supraclavicular node, and respiratory examination. Patient had a bilateral air entry both sides, which is equal, and the normal vesicular sound present in the both sides. Serious examination, S1, S2 is normal, no other heart sounds audible. In the CNS examination, non-significant, all sensation and power in the both limb are present in detached. And next move to the per abdomen examination. On inspection, should I comment? Per abdomen examination on inspection, there is a localized distension seen in the predominantly in the umbilical and the left lumbar region. Umbilicus is centrally placed and inverted. Skin appears normal. No visual peristalsis, pulsation, or no distal dilated veins, and no trace seen of the abdominal skin or lumpy skin. It is a scar seen in the left inguinal-scrotal region, which is medial to the anterior superior spine and reach up to the upper part of the scrotum. No movement of the lump seen with the respiration. No obvious herniation or cough on impulse on herniation side. On genital inspection, left side scrotum looks higher than the right side and appears empty as compared to the right side. On a palpation, we confirm our inspection finding on palpation. So is a 15 into 10 centimeter single non-tender non-mobile lump felt in the umbilical and left lumbar region predominantly, but also involve left leg fossa and hypogastric region also, and it also crossing the midline. So clearly it extends 4 centimeter below the sternum and inferiorly it reach 4 centimeter above the pelvic symphysis. On the left side, it's 8 centimeter from left side and 2 centimeter from midline to right side. So no rising local temperature, no tenderness, no guarding, no rigidity, no movement with respiration, non-mobile in all directions, non-rotable, no pulsation. On the percussion of the abdomen, tympanic note all over the abdomen, except dullness over the lung, no shifting dullness elicited, no horseshoe-shaped dullness. On auscultation finding, there is a predominantly all sound seen on the right side. It appears normal. And scrotal examination, no testes felt in the left scrotum, testes felt in the right side with no palpable swelling, no tenderness, and no hernial sign. And testicular sensation is intact on the right side testes. So my summary for this patient, sir, a 22-year male, married male, uh, presented with the left side testicular swelling since 1 year, abdominal lump since 3 months, and low back since 3 weeks. And he underwent surgical procedure for testicular swelling 2 months back, and it's a large abdominal lump, 15 to 10 centimeter, which is non-movable with the respiration and non-mobile in the all direction, non-tender. So this is my patient summary.
Any question by anyone? By examination, kind of surgical procedure is underwent.
So he underwent the high inguinal artery treatment for the testicular. Yes, sir. Explain, sir. Left side inguinal scrotal scar present, which is medial to the anterior scrotal extent and reaches up to the upper part of scrotum. And is healthy. Its length around 7 to 8 centimeters. My differential diagnosis for this patient has a history of the left testicular swelling with the progressive abdominal lump. My first differential for this patient is germ cell tumor, and my second differential is less likely lymphoma. There is no these symptoms and also presented with the left testicular swelling. So first is germ cell tumor for lymphoma. Yes, sir. Patient has a normal. I didn't measure, sir, but it's the patient not any malformed feature, no arms, no tall stature, no any polydactyly, syndactyly, or other malformed features. How do I examine the patient? Patient examination, sir, standing position with initial inspection, and after that palpation, and then after that sensation activation. So left side there is no testis felt, right side is testis present, but there is no swelling or growth over the or out around the testis.
What are other testicles?
So there is a hydrocele testicle. Other cell germ cell tumor, there's lymphoma and other malignancies like mesothelioma and rare malignancies of the testes, carcinoma, secondary.
Before that, another common malignancy which is seen at this age, but not at this age, apart from lymphoma, rhabdomyosarcoma. That is a more closer differential. I think some points in the discussion in the. So, what have you told about the family history? Is there any importance of family history?
No, sir, there is no family history. Yes, sir. Germ cell tumor is the importance of the family history.
What is that? What is that?
Sir, if patient had a first closely related like patient whether is affected with germ cell tumor, there is 8 to 10 times risk of the developing germ cell tumor. But patient father has a germ cell tumor, and chances is 2 to 3 times higher relative risk.
So there is some data which shows, but as such, there is any specific gene or something that is still not. But definitely there is some family history. So based on the history, what the one differential diagnosis told about lymphoma, and I think before lymphoma you should put the rhabdomyosarcoma, because that is the age, at least 18, 20, that is the rhabdomyosarcoma fits into that age group. And in the examination, what are other findings which you could have mentioned in a case of testicular tumor?
Sir, gynecomastia and liver failure signs, sir.
देखो क्या है, I think how many times you have seen a testicular cancer patient presenting with liver failure?
That's right.
Hmm?
No, sir, rarely.
So I think based on my experience with the previous examination, that try to avoid those words which are very, very rarely seen in that particular cancer. So I think the more important point which you could have addressed regarding the gonadal dysgenesis, like the features associated with the Klinefelter syndrome, because ultimately that is one of the important underlying region, or the patients who are having dysgonadogenesis, they are prone for developing the testicular cancer. So I think you could have mentioned about the feature suggestive of the arm length span. So whatever the secondary sexual characters and all that, that may hint an idea about the is there any underlying testicular dysgenesis is not in that. So I think that point you could have taken into the your general examination, which might have pointed out towards this. The other thing, have you told about patient is married, unmarried, having kid or not?
Yes,
that is
married
very important.
and one kid, sir. It's a 3-year-old.
So that is a very important point that should come in other cancer cases. It's important, but in this case, it's very, very important, because sometimes the patient might getting worked up for a agiospermia or oligospermia, and that during workup they found that there is a lesion, and the therapeutic implication for this is also there, that already there is a one kid, whether they want to go ahead with any other sperm banking or not. So the family history and married life history and the kids, that should come into the discussion part of a history and this. So I think that point you should have taken. And as I told you, avoid the things which we rarely see in that. If any examiner asks that, then you can tell.
Yes.
But it's very.
Sir, your voice is not.
Yes. So I think Ajay and Dr. Kumar is there. They can lead that. I will just pitch on whenever required.
Yes.
I think Akhil is there, so Akhil can also ask the question if he's there. Akhil or Dr.
Akhil, any questions? Any comments? Or Mishraji is also there.
Yes, sir. So for this patient, we would like to work up for diagnosis and staging. Yes, sir. So we like to do a workup for the staging and the diagnosis. So I would go with the our routine blood examination with CBC, LFT, RFT, and with electrolyte and calcium, and USC scrotum and tumor marker, AFP, beta SCG, and LDH. And after that, the contrast enhanced CT scan of the thorax, abdomen, and the pelvis. And if we found any significant tumor marker and patient has a large abdominal lump, so either we can proceed for the treatment, early treatment, or we can plan for the biopsy for the patient accordingly.
But you say high order and that report is there with us.
No,
So that is there with the patient.
yes, sir.
Has the patient brought the report?
Yes, sir. It's written on one discharge card. It looks written like a tuberculosis orchitis.
Tuberculosis orchitis.
Yes, sir.
And we have the reports.
No.
Reports are there. Reports. EMR.
So patient doesn't have a block. Block. Patient doesn't have a block of other.
But reports से क्या आगे जो भी टेस्ट बोल रहे
हाँ,
थे
sir.
EMR marker करना
Yes, sir. Yes, sir.
वो बताते जाओ
Yes, sir. Yes.
you wanted to do CT scan thorax abdomen and pelvis isn't it?
Yes, sir.
Wanted to do human marker.
Yes, sir.
Which human markers?
Yes, sir. AFP and beta HCG and yes, sir.
Okay, pause for that.
So AFP of the patient is 1600 and beta HCG is 10,100.
Okay. And CT scan abdomen?
Yes, sir. CCT abdomen is done, sir. It's a left side predominantly retroperitoneal mass, which is started in the pre-aortic region and brings up to the pubis region. Its size is cranial is 13 centimeter and transverse is 10 centimeter and depth wise is around 11 centimeters. And patient had on a thorax, there is two nodules in the left side upper lobe.
Left side upper two.
And one lesion in the liver also.
One is in the
Liver, yes, sir. It's only 1 into 1 centimeter. So they are not sure about that lesion is metastatic or not.
metastatic.
Yes.
Does it make a difference that liver lesion is what?
Yes, sir. This because it's a non-purgatory max and patient goes under the poor risk.
तो कैसे confirm करें disease है कि नहीं liver में?
So we can plan for a patient has a we can plan for the USG target for to see the liver lesion nature. It's a hypoetic or hypodense lesion.
Any other way? So what we are confused with here, if there is a lesion, what do we confuse with? There's only two things we get confused with. ये vascular malformation है कि नहीं and दूसरा cyst है कि नहीं?
Yes, sir. Yes.
Otherwise, तो कैसे differentiate करते हैं इसे? Anyone? Liver lesion, metastatic or not? How do we confirm? Or what do we do to be relatively confirm? Confirm तो है कि आप disease को देखो disease है कि नहीं? Microscope. Ultrasound, yes, one way to do it. That also helps. Definitely तो ultrasound तो आप tissue तो उसके अलावा बोले तो तो बात है therapy के पहले he wants to know which risk group, he wants to know plan B, P4 or PP4 है ना? CT scan में कुछ कर सकते हैं which may help you in knowing the features. Triphase hypothesis that may help you. किस चीज पे cyst में? हाँ जोर से बोलो ना किससे differentiate करने के लिए triphasic contrast cyst versus mets और vascular malformation बहुत बढ़िया correct and cyst versus mets के लिए USG this one and CT scan में अब ये चीज थोड़ा आना क्योंकि आप ये चीज क्वेश्चन आएगी कि भाई कैसे करोगे डिफरेंशिएट है ना अब तुमने क्या बोला लंग में दो नोड्यूल है दो नोड्यूल मेटास्टैटिक है
Yes, sir. They appears metastatic.
दे अपीयर्स मेटास्टैटिक फिर वो अपीयर्स मेटास्टैटिक योर आईज वर्सेस माय आईज हो जाएगा तो कैरेक्टराइज करोगे यू हैव टू सी समथिंग
Yes, sir.
ये योर एक्सपीरियंस ऑफ थिंग आप 4 साल से देख रहे हो तो कैन से बट देयर यू हैव टू आंसर कि व्हाई यू आर सेइंग मेटास्टैटिक तो क्या बोलोगे
It's an enhanced region, which size is one nodule size is 2 into 2 centimeter, and it's irregular margins.
इरेगुलर मार्जिन ओके तो मेट्स में इरेगुलर मार्जिन होता है या प्राइमरी में मैं बोल लंग कैंसर तो नहीं
Size is small, and we had a large
स्मॉल
abdomen.
साइज नहीं था T1 कितना साइज होता है उसमें भी कैसे बोलोगे लंग प्राइमरी नहीं है वर्सेस ये इसमें आंसर करना होता है आई डोंट नो कि दिस विल लुक अ बिट एब्स्ट्रैक्ट क्वेश्चन बट खुद आ सकते हैं से 22 ईयर ओल्ड है सर नॉन स्मोकर है एक डिजीज है वी यूजुअली एक्सप्लेन विद द डिजीज टू नोड्यूल्स हैं नोड्यूल्स सी वेयर यू मेड अ मिस्टेक ऑफ सेइंग अब मैंने देखा नहीं है स्कैन वी सेइंग देयर इज अ लीजन व्हिच इज जनरली जो मेट्स होते हैं ना खासकर जर्म सेल ट्यूमर के या फिर थायराइड के यूजुअली पॉइंट शेप हमारे टाइम में पढ़ाया जाता था, कॉइन से लगा कर ऐसे देखते हैं, बट आप बोलोगे कि नहीं मार्जिन नो उसके इनफिल्ट्रेटिव है, तो फिर क्वेश्चन कम्स की कैन बी नॉन-ट्यूमर, करेक्ट? बी केयरफुल कि आप क्या बोलते हो, enhancing है कि नहीं, you will see in lung window, you will see in the soft tissue window, then you have to say कि you have ruled out calcification, ये मेटास्टेटिक डिजीज है, करेक्ट? तो ये सारा आपको बोलना पड़ेगा, जब आपको पूछेगा कि भाई क्यों बोल रहे हो ये, you have to answer it. अब देखो उधर मैं बोलना पूछना भूल गया, कैन इट बी लिवर प्राइमरी, आप एफबीपी हाई बोल रहे हो, बोले भाई लिवर प्राइमरी भी तो हो सकती है, जर्म सेल ट्यूमर भी तो लिवर प्राइमरी। कल ही किसी ने कॉल किया मुझे अहमदाबाद से, और this what and now I always confused कि हमेशा ये बोलना चाहिए कि नहीं जो बेटा इस सेट, which is yeah you should continue saying that उसको ब्रेस्ट कैंसर था and there were 2 lung nodules, नहीं ब्रेस्ट में, so क्या था, squamous and followed by this was adeno, was the site he said, and they thought mets but they did a biopsy and they found adenocarcinoma, so it turns out to be totally different primary, and 2 lesions there, so they got segmentectomy done, and then after some time the new nodule came, so now they have done lobectomy. The question was what to do next, that was a discussion, but again I'm giving you an example, so again you have to have an answer कि भाई the liver lesion कैसे दिखता है, eyeballing is your eyeballing, तो हम OPD की बात कर रहे हैं, यहाँ you are able to answer these are features in the scan which may suggest liver primary, and these are features which suggest liver mets, correct? फिर उसके बाद तुम क्या बोले, लिवर का हो गया तुम्हें, और लंग लीजन हो गया, एब्डोमेन में कितना बताया तुमने, 14 into some
14 into 10 13 centimeters,
14 into 13 सेंटीमीटर, और जस्ट भी कुछ बता रहे 10-12 सेंटीमीटर, फिर और स्कैन में क्या देखोगे, अगर इतनी बड़ी लीजन है तो स्कैन में और क्या देखोगे, एनीवन? आपको है उसमें या नहीं, बताया नहीं यार, अब वो तो तुम्हारा ट्रीटमेंट में फर्क पड़ रहा है, so that should be noted from you, yeah you have noted it, और जब इतनी बड़ी लीजन है तो और भी कुछ हिस्ट्री में तुमने पूछा होगा मोस्ट लाइकली, पावर डिस्टर्बेंसेस तो नहीं है,
नो पावर डिस्टर्बेंसेस,
ब्लैडर
नो
डिस्टर्बेंस
नहीं,
बहुत बढ़िया, तो आपकी ये सारी हो गई, और कुछ रह गया, अच्छा उसका सीबीसी बाय, अच्छा वो आगे है, सीबीसी बाय तो से देख लीजिए,
yes all are normal,
ऑल आर
all
नॉर्मल,
yes.
ऑल आर नॉर्मल, हीमोग्लोबिन कितना है,
So 16.1
16.1,
yes,
तो रियली फास्ट, तो हीमोग्लोबिन में फर्क ही नहीं आया, चलो बहुत बढ़िया, एंड यूरिक एसिड इज नॉर्मल,
yes sir, not in TLS,
कैसा फास्ट ग्रोइंग ट्यूमर है कि टीएलएस भी नहीं करता है, तो ठीक है ये भी अच्छा है, सो यू नो दिस ऑल यू सरप्राइजेस यू गेट इन स्पाइट ऑफ ऑल, एल्बुमिन इज नॉर्मल,
yes, so 4.1,
4.1, so ये you know is a disease which looks like otherwise is very fit, बहुत बढ़िया, अच्छा रिपोर्ट दिखा रहे हो, अच्छा कोई बात नहीं, ये हमारा इट इज इंपॉर्टेंट टू सी सीबीसी बायोकेमिस्ट्री एंड इलेक्ट्रोलाइट्स आर नॉर्मल,
yes
कौन कौन से इलेक्ट्रोलाइट्स की,
sir, for sodium, potassium and calcium,
बहुत बढ़िया,
or additional imaging में what you want to see other, as Dr. Kumar was asking, what other thing you want to see with such a large abdominal mass, what other thing you will like to rule out before proceeding further?
yes sir, raised beta ECG more than 5,000 and patient very large abdominal, so we
No, in imaging, he was asking in imaging, or what you want to be careful, or what you want to extra investigate as with such a huge abdominal mass, and which is commonly which can be seen in testicular cancer patients, which can present as a surprise after giving the chemotherapy. You want to rule out the DVT in this because it's such a huge abdominal mass. You have to just be careful, just palpate the lower limb and discuss with the radiologist is there any, or sometimes if there is suspicion you can go for a Doppler study of lower, because with long standing abdominal mass compressing the vessels, there is a theoretical possibility of this thing DVT, not sometimes DVT, and above the DVT also the common iliac vein, there might be, most commonly it will be the pressure, or so rarely the tumor thrombus can be there.
ये बड़ा इम्पोर्टेंट है, डीवीटी एमआरआई तुम बोल रहे थे करोगे, किस किस सिचुएशन में एमआरआई करते हैं? एक चीज दो आप बता रहे थे।
Yes, sir.
क्या बोल
MRI brain when beta SCG more than 5 centimeter diffuse pulmonary vents.
एंड एक्स्ट्रा पल्मोनरी
Extrapulmonary disease. Yes.
सीबीसी दिखाने वाले तो दिखाई दे तो दिखाई दे। In the meantime, anyone any question for investigation? Dr. Linda, Dr. Sushmita, Akhil and Mishra ji, Dr. Akhil and Dr. Mishra ji, any questions for investigation? ऊपर एक बार दिखा दो आपको। बस keep going down, 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 keep going down.
No questions from his side.
Thank you, thank you. Because red क्यों है? हाँ बस तो ये लो ही था, लो की वजह से बहुत बड़े गुड, ठीक है गुड, that was nice. So देखो ये पूछते हैं वहाँ पे and they open the investigation exam, so that's the reason I opened, so you should know कि open करते हैं तो was the liver lesion characterized?
No, sir. नहीं sir, अभी मैं अभी नहीं हूँ. One liver lesion.
So that is a valid point. The moment you have one lesion somewhere, be careful. Have the question to radiologist to confirm or to report otherwise. So this was regarding investigation.
I think what Dr. Kumar was saying very important. Sometimes they will open the CT scan film. So I think we should have at least basic idea how to we read. So how the liver lesion is looking like where is the actual position of the para-aortic lymph node. So I will not say that you read in detail, but at least you should know the gross structures of the abdomen. If the examiner opens the CT film, you should at least grossly know that this is the para-aortic lymph node. These are the region is the primary drainage area. So I think in the last exam, I will not name, but one resident is not able to identify the psoas muscle, and he told that bilateral lymph. So that was very odd moment for us. So they may open, and in long case, definitely either it will be mammography or whatever case you get, the CT scan film most likely the examiner will open. So you should have a basic idea of reading this mammography and the CCT thorax and MRI brain. Nobody will ask much, but CCT thorax and abdomen and pelvis we should know.
ये जरूरी है, थोड़ा देख लेना. इनफैक्ट को एम्स में तो रेडियोलॉजिस्ट कम्स एंड टेक्स एग्जाम. वो रेडियोलॉजिस्ट का पार्ट ना, वो रेडियोलॉजिस्ट आके वो स्कैन लेके आते हैं, वो सारा वो पूछते हैं. आप बोलो तो वी कैन स्टार्ट हियर इफ यू इंटरेस्टेड, बट आई गिव इट टू यू. ठीक है, बट इन द मीन टाइम हैव दैट आइडेंटिटी. वो थोड़ा सा ऑकवर्ड हो जाता है. इफ यू कांट आइडेंटिफाई कि लेफ्ट वेंट्रिकल कौन है और ये एट्रियम कौन है, तो इट मे बिकम अ बिट ऑकवर्ड सिचुएशन. तो ऐसा नहीं होना चाहिए. तो गो थ्रू इट इफ रिक्वायर्ड. टॉक टू रेडियोलॉजिस्ट, have some classes for identifying those structures, and if required, let me know. I'll be happy to talk to them. But after the second year, do these things from now. In the OPD, you always have an issue. What we हम comment के लिए भेज देते हैं. Don't do that. अब देखो मेरी OPD में तो नहीं करता. मेरी OPD तो मैं उनको भेजता हूँ. अभी जो भी मेरे साथ अभी बैठते होगा, कौन बैठता है? आदित्य. तो आदित्य भागते हो कि आदित्य है नहीं. अच्छा वो फर्स्ट ईयर. अच्छा वो तो देखो मैं तो पकड़ के भेजता जाओ के डिस्कस करके आओ, करेक्ट, जो भी साथ में. तो गेट अ हैबिट ऑफ इट. इट इज यूजफुल फॉर यू. दैट आई बॉलिंग वो 10 बार आदमी देखते हैं ना, तभी याद रहता है. तो कहाँ से स्ट्रक्चर याद रहता है वो? इफ यू सिट विद द रेडियोलॉजिस्ट, देखो ये यहाँ पर है, ये यहाँ पर है, देन पैसिवली दैट डजंट मीन यू बिकम अ रेडियोलॉजिस्ट, बट यू डू अंडरस्टैंड. आई शुड ट्राई टू सी. Then your conversation with radiologist will be far better. Do it 10 times, and then you will realize, oh, you are starting questioning. Hey, clinically, it's not looking that way. Correct, Ajay? Na? Ajay, and we do it so regularly. So now we know how useful it is. तो ये मैं बोलूँगा सेकेंड ईयर को देखो अभी से करो. आप स्कैन रख लो. Any OPD, no one will stop you from doing that. Take those scan, have a discussion. Take those half an hour with your radiology colleague, any consultant, especially the young ones, and spend them time identifying things, what it means. So आप identify करो lesion के लिए, आप primarily discussion के लिए जाओगे, but that may help you understanding the scan. ठीक है, तो ये सेकंड के लिए, थर्ड ईयर के लिए तो वॉन्ट हैव अ क्लास, गो अहेड। उसके बाद और कोई इन्वेस्टिगेशन?
Yes, so we can plan the biopsy from the abdomen.
बायोप्सी फ्रॉम एब्डोमिनल। अच्छा, बहुत बढ़िया। तो जरूरी है क्या बायोप्सी?
No,
नॉट,
Yes, sir.
क्यों रीजन?
large abdomen lump, and it may be life threatening, so we need to start treatment early and raise tumor marker and history of the testicular surgery or abdomen lump. So
सर्जरी हो गई है, मास
mass
है,
bada and
tumor
tumor
markers
marker
है।
raised. Yes, sir.
ओके,
So
तो
on the basis of we can start.
वी कैन स्टार्ट। क्या बोलते हो डॉक्टर लिंगराज? फिर तो अगर तो क्वेश्चन ये आ जाएगा कि अगर एएफपी बीटा सी रेज है और कहाँ रेज हो सकता है, एक क्वेश्चन है।
Yes.
हाँ, नो, एंड कैन दैट लिमिट अस नोइंग दैट, एंड दैट में हेल्प अस कि हम स्टार्ट कर सकते हैं। तो कहाँ रेज हो सकता है बीटा सी?
AFP beta SCG
तो
raising.
जैसे आप बोलोगे मैं स्टार्ट करूंगा तो नेक्स्ट क्वेश्चन विल कम कि वेयर एल्स बीटा सी कैन बी रेज्ड, बट ठीक है, यू कैन ऑलवेज हैव आर्गुमेंट्स सर एब्डोमिनल मास यहां पर है, आई एम सेइंग इन दैट कॉन्टेक्स्ट, बट इट कैन ऑलवेज बी देयर वेयर एल्स बीटा सी कैन बी रेज्ड।
AFP is also in liver condition like cirrhosis or hepatitis, and beta SCG raised in hypogonadism, or those are the marijuana predictor.
अच्छा, अभी तो इसमें तो काफी रेज है, कितना रेज तुम बोल रहे हो?
Sir, 10,100.
10?
10,100.
10,100। मान लो कि हंड्रेड्स में हो, is there a way of knowing the different subtypes of beta SCG? कोई मतलब है या उसका कोई मतलब?
That one unit with the.
देखो तुम्हारा एग्जाम है, मेरा थोड़ी है। मुझसे कुछ मैं तो आसान है, अपना क्वेश्चन पूछ दिया, अब आंसर तो तुम्हें करना है। और एएफपी और कहाँ रेज होता है? एक लिवर बताया है, और भी कहीं होता है और कहीं नहीं होता। वेरी गुड। और बीटा एससी कहाँ रेज होता है? लिस्ट दी है तो एनसीसीएम में, मैं तो एनसीसीएम से बताऊंगा, तो पढ़ के बताओगे।
Beta SCG in female pregnancy, miscarriage, and
मैं ट्यूमर की बात करूं तो वेयर द पॉसिबिलिटी, देखो बड़ा कम हम देखते हैं, बट इट इज वेरी अनकॉमन। मैंने भी पढ़ा जब, तो देन आई रियलाइज कि अच्छा मैंने कितनी बार देखा है। तो बट हैविंग सेड दैट, देखो एग्जाम में इफ यू आर एबल टू एनुमरेट, पीपल विल मूव फॉरवर्ड। अब देखो नहीं तो मैं अटक गया तो आपके साथ, अब मैं भी एक क्वेश्चन में 10 मिनट पूछूंगा आपसे, फिर क्या मेथड होगा। मान लो कि आपने, मैंने पूछा क्वेश्चन कहाँ रेज होता है, आपने 3-4 ट्यूमर बताए, बीटा एससीजी के 3-4 बताए, एएफपी, मैं भी बोला रे यार इसको तो सब आता है, चलो दूसरा क्वेश्चन पूछते हैं। जैसे मैं देखा आप अटक गए बोलने में, देन आई एम स्टक हियर, फिर मैं उसकी हाफ लाइफ पूछूंगा, तो उसका कोई मतलब नहीं। यू वांट टू गो टू ट्रीटमेंट, जो आपका स्ट्रेंथ है ना, तो इसलिए ये चीजें थोड़ी याद करनी जरूरी होती है। तो आज पढ़ करके सर्कुलेट करूंगा सबको, किस ट्यूमर में इंसिजन में दी हुई है, डिस्क्रिप्शन में दी हुई है, उसकी उन्होंने अलग से नहीं दी हुई है टेबुलेशन में, पर डिस्क्रिप्शन में दी हुई है। तो दैट में करके ये करके, तो मैं बोलूंगा फिर याद करोगे नहीं आप लोग, उसका फायदा नहीं है। वो खुद पढ़ के अगर करोगे सर्कुलेट, तो फिर वो थोड़ा याद रहेगा। तो कहाँ रेज होता है, जिससे यू कैन पुट इट कि देखो यहाँ होता है, बट दिस डजंट फिट इनटू दिस कंडीशन, इसलिए दैट्स द रीजन यू आर थिंकिंग ऑफ स्टार्टिंग ट्रीटमेंट। तो वी कैन स्टार्ट ट्रीटमेंट, है ना। तो अब देखो ट्रीटमेंट कैसे प्लान करोगे?
So we plan for the prephase for this patient first.
देखो पूरा प्लान बताओगे ना। देखो अमित ने क्या समझाया कल, यू नो कि यू हैव टू हैव अ फुल प्लानिंग। आप बताओगे ये करूंगा, ये ऐसे रहेगा, डायग्नोसिस ये है, ये रिस्क ग्रुप है, ये आज कंडीशन ये है इसकी, इसकी वजह से मैं ये ट्रीटमेंट दूंगा सर।
So for this patient, this is a non-seminal germ cell tumor. Sir, right now with the no liver lesion characterization, it's intermediate risk. If liver lesion is positive, then it's a poor risk patient. But in your large abdomen, we plan.
आगे सोच रहे हो कैरेक्टराइज करने के लिए?
Yes, sir.
तो कैसे कैरेक्टराइज करो? तुम तो कीमोथेरेपी भी सोच रहे हो कल स्टार्ट कर। अगर मैं बोलूं जर्म सेल ट्यूमर इज अ बिट लाइक लिम्फोमा, तो मैं गलत तो नहीं बोल रहा हूँ। डॉक्टर लिंगराज देयर, इसमें मुझसे परमिशन भी लेता हूँ, सही बोल रहा हूँ ना कि उसके बाद आप दे दिए अगर सिस्प्लेटिन, तो पता नहीं वहाँ क्या मिलेगा आपको। तो अगर मान लो कैरेक्टराइज नहीं कर पा रहे हो, तो क्या रूल ऑफ थंब होता है ऑन्कोलॉजी में ट्रीटमेंट?
Over.
थोड़ा सा हम जनरली ओवर, तो वी हैव टू टेक इट एट टुडेस टाइम। आप स्कैन डिस्कस कर सकते हो, स्कैन यू हैव डिस्कस वंस दे हैव सेड कि अरे मेटास्टेटिक यू हैव टेकन इट, चलो बहुत बढ़िया। तो अब क्या करोगे?
So sir, we plan for the prephase patient with the.
आगे इस ग्रुप पे तुम थे?
Yes sir.
नॉट एनएसजीसीटी?
Yes sir.
उसके
And
बाद
NSGT right now is intermediate risk, and with the large abdominal lump, and breast tumor.
Liver region से भी intermediate risk?
नहीं sir, poor risk.
Poor risk.
Poor risk. Poor risk and large abdominal lumps. So we plan for the prephase with the anti-TLS.
उसके poor risk हो गया?
Yes sir.
Okay, बहुत बढ़िया. And the patient has a large abdominal mass, इसलिए आप plan करोगे prephase के लिए.
Yes sir.
उसके बाद की plan कौन करेगा?
Prephase with anti-TLS prophylaxis with the cisplatin 20 mg per meter squared for 2 days or 3 days, and etoposide 100 mg per meter squared 2 days or 3 days with hydration and anti-TLS prophylaxis. And after 1 week, within 1 week we do the other further chemo fitness investigation with the PFT-DLCO, PTA, and ECG-2 for the patient. And if patient general condition improve, lump is shrink, no TLS, then we plan for the 4-cycle BEP for this patient.
4-cycle BEP.
Yes.
अब देखो ये तो बोल रहे देखो कल मिस कर गए एक चीज ये फैमिली का कुछ
Yes sir, preservation, semen preservation.
चलो बहुत बढ़िया. So this will be our overall plan. Anyone else? Dr. Ajay, Dr. Amit.
So what is the AFP level, tumor marker level? I missed.
Yes sir, sir. AFP is 1600 and beta is 10,100.
So by a tumor marker, patient is falling into which risk group?
Sir, intermediate.
So the management of an intermediate and poor will differ by any chance?
Yes sir. Only sir, same sir. For intermediate and poor is the same.
Yes. So regarding the definitely we need to clearly know the liver lesion, but indirectly if you give chemotherapy, if the liver lesion disappear after 4 cycles of chemotherapy, in this case the prognosis, what are the cure rates for a different risk category group with the current that ICGCCC?
Yes, for the good risk patient, there is a 5-year-old survival is 96%. For the intermediate risk is 89%, and for the poor risk is 67%. So
it is how much?
for poor risk, 1% poor risk.
So what is the difference between the previous ICGCC 1 and 2?
Yes, sir.
What are the differences?
Mainly difference in the poor risk. The previous poor risk 5-year-old survival is around 40%.
And anything in the seminoma? Have they commented anything on the seminoma?
Seminoma is almost similar. Seminoma, both intermediate, both are almost similar. No.
Have you read that paper fully?
Yes, sir.
Have you read that paper, that ICGC2 paper?
Yes, sir.
So was there any additional comment for seminoma risk stratification?
Yes, sir. They commented with the LDS level also, sir.
Yes. So that is still not
more than 2.5. Then survival is 92%.
Yes.
And
so they recommended that can be a basis for keeping this seminoma patient with high LDS into the, though it has not been implemented till now. That is one additional suggestion the group has made. So why the survival of a patient has improved over time? Because the BP is being used for years. So why the difference between survival of ICGC 1 and 2, why the survival has drastically improved over time? We are using the same chemotherapy regime.
Because the increased survivorship, we had a survivorship, supportive care, and salvage treatment.
Anyone else? Any other students who wants to comment on this? So basically, it's the better supportive care for these patients. So now more more experienced center coming up with the tackling this tumor and more aggressive approach for a RPLND, the surgeon community, the uro-oncological community. So basically, we have to push up our surgeon to go for an aggressive resection for this tumor. So the survival has improved because of the better supportive care, more trained staff, more trained medical oncologists dealing with the testicular cancer, and with the more aggressive surgery done by uro surgeon or thoracic surgeon for mediastinal. So that is the reason with the better supportive care, the survival have increased over a period of time.
So anyone else? Ajay, any comment? Any question regarding treatment? Dr. Akhil and Dr. Mishra ji? Eh,
No question. No question.
Dr. Akhil, any question?
So what is your criteria for, so why you want to do PFT-DLCO? What's the importance and how you will take the value in managing this?
For the bleomycin, sir, we can allow patient for the mild restriction. So DLCO more than 60%, we can consider for the bleomycin therapy for the patient. If it is less than 60%, then it is the contraindication for the bleomycin, which will lead to the pulmonary fibrosis. So
then what will be the alternative regime?
Sir, VIP.
So again, but Dr. Kumar was saying that don't say full, try to say the full regime, the name of the chemotherapy molecule.
This is the VIP regime, sir, with the etoposide, ifosfamide, and cisplatin. In the etoposide, 75 mg per meter square day 1 to day 5, and ifosfamide 1.2 gram per meter square day 1 to day 5, and cisplatin 20 mg per meter square day 1 to day 5.
So this was regarding the treatment part. So you've told what you will give. So what you do after how many cycles you want to give?
4 cycles.
4. So when you will not give PP?
So patient absolute age is 45 years or renal insufficiency, and patient has a known previously cardiac pulmonary comorbidities with the COPD changes and emphysema or tuberculosis, or heavy smoker patient also about bleomycin.
So you said you will give 4 cycles.
4 cycles.
उसके बाद क्या करोगे?
After that, sir, we plan for the response evaluation. So after 4 to 6 weeks, we plan for the CCT, abdomen, thorax, and pelvis. If residual disease present more than 1 centimeter, then we plan for the dissection.
In इसके पहले, before CT scan, what the other thing is
tumor marker, sir.
Yeah, so that is the first thing you want to see. And do you want to see the tumor assessment in between?
Yes, sir.
So do you want to repeat the tumor marker in between? And
yes, sir. So we want to repeat after 1 cycle, sir.
There will be 2 scenarios. One scenario, the tumor marker is falling. Another scenario, the tumor marker has not fallen. So will you change?
Tumor marker is falling, then we continue with the same treatment. If tumor marker is not falling, then we have to move to the intense regime, like VIP or TIP.
Is there any data which suggests that this changing the treatment in between and with this regime, the TIP has helped? So why you want to change?
So those tumors not falling, that they get benefit with the response rate when they change with the intense chemotherapy regime. India now,
so we will use the TIP if the patient, if you are in a very good center with all assets to tackle the toxicity, and the tumor marker has not, there was not log fall after 1 cycle. Then you want to go some other chemotherapy regime, or you want to TIP or VIP or any other regime? Do we practice at our center this strategy?
No, sir.
So whatever the data available for changing the treatment, that is only one paper, the GTOG study, some number study 18 or 20. So the regime which is being used for patients who are not having a log fall, it's a very complicated, very toxic regime with having lot of cycle of bleomycin with paclitaxel with oxaliplatin. So theoretically there is a regime, but practically applicability of this regime in our day-to-day setup is practically difficult, and I don't think so anybody in India at least uses the approach. Changing to TIP or is not the standard. With the GTOG regime is the way go ahead, but I don't think so anybody uses that toxic regime in day-to-day setting. So we if we see the fall, if there is no fall, the prognosis may change, but we in our day-to-day practice we doesn't change the regime till now. I think Dr. Kumar can comment on this.
Agree with you, Dr. First cycle. Many people do every cycle, but you can choose, because people are not so certain about it, how exactly you change your treatment. So you said after 4 cycles, if there is a residual disease, so तभी देखो आंसर होना evaluate कैसे करेंगे? अब देखो आप OPD में क्या करोगे और जहाँ प्रैक्टिस में क्या करोगे आप करोगे? एक क्लिनिकल जो एग्जामिनेशन या क्लिनिकल इवैल्यूएशन कभी बोलना है तो and we do it by now. कैसे हो भाई? आप पूछते हो ना पेशेंट से, you partly judge your patient clinically कि कैसा है वो, how patient feels, how patient is doing. You may or may not put a hand, which you should try to. Once you have now full quorum of resident, then you should say that, because that is something starts with, then you can go to what you said. That's perfectly fine. So ये कर लिया, उसके बाद residual disease, then you said what you will do?
Sir, if residual is more than 1 centimeter, then we plan for the resection.
Okay, so then 1.5 centimeter lateral petal lymph node है, और जो lung lesion है, that is around 1 centimeter left, and liver lesion is around 6 millimeter left. अब क्या करें?
Sir, we plan for the surgery that there is a maximum bulk of the disease, and at the we can do this. We can dissect the all lesion, or after the primary bulk surgery, we do the histopath. So it's a necrosis. There is a probability of the all site process. 90% probability of the all site had the same prognosis, the same histology. So we can observe or biopsy for that lesion, or we surgery is a bulky site.
बहुत बढ़िया. तो जो सर्जरी करेंगे, what we do surgery in the abdomen, what you said, उसमें what is the chance of कि necrosis होगी, what is the chance of कि और कुछ हो सकता है?
So 50% teratoma, 40% necrosis, and 10% teratoma.
So हम लोग के टाइम में आसान था, 1/3, अभी चेंज हो गया होगा तो कोई that's perfectly fine to do it. तीनों सिचुएशन में क्या करोगे?
Sir, after surgery, teratoma, then observation, necrosis, then observation. If viable tumor is present, then we plan conservative chemotherapy. The patient is a poor risk, 2 cycle EP or 2 cycle VBI.
Okay, ठीक है. तो अब ये तुमने बता दिया कि तुम इसके बाद क्या करोगे. उसके बाद subsequent to that patient को क्या करोगे?
Subsequently, patient on observation circuit, tumor marker and clinical examinations.
Tumor marker क्या daily कराओगे?
No, sir, every 3 to 4 months, up to 2 years, and CT abdomen and pelvis every 6 months, and chest X-ray every 6 months up to 2 years, and then we do 6 monthly tumor marker clinical examination, and after that annually.
बहुत बढ़िया. क्या चांस है कि इस बीमारी का what you have seen coming back? What is the chance that disease may come back?
Yes, sir. So for the late relapse is 10% chances of the systemic relapse.
So 90% is the survival for this group of patients.
Poor risk is 70.
अभी तो तुम बता रहे थे, डॉक्टर अमित ने पूछा, आपने इतना बढ़िया जवाब दिया कि देखो वो चेंज हो गया 52 से समथिंग कुछ बता रहे थे.
Yes, sir. 30% patient relapse.
तो वो जो relapse हो गया, how do you again how do you approach for management?
Yes, sir. So we can approach for the patient for the salvage treatment, sir. So with the cisplatin regime, sir. So previously the patient received BAP, so there's we can avoid bleomycin. So we can proceed with the VIP or TIP, sir. For 4 cycles, and after that response accordingly.
BMT कब करवाओगे या नहीं करवाओगे?
Yes, sir, there is a one study that compared VIP versus the high dose chemotherapy. They didn't find any survival improvement, but there is some cavities and fall velocities, and the study keep that.
Which are the patients where you would think if these features are there, I'll consider for?
Sir, those who are mediastinal germ cell tumor.
सिर्फ mediastinal germ cell. अगर testicular germ cell tumor 2 साल बाद आया, कीमोथेरेपी दिया, अच्छा रिस्पॉन्स है?
No, sir. So more than late relapse, so there is a different approach for idos that city.
What I'm saying, remember some criteria. In these situations, we consider for BMT.
Sir,
any criteria one remember. So I'm not saying asking for your trial, but that you should be able to remember कि देखो पेशेंट ये होना चाहिए, कीमो रिस्पॉन्सिव होना चाहिए, इतने टाइम में फेल होना चाहिए, ये उसका एज ग्रुप होना चाहिए. Those things are features are there. I'll consider for.
Yes. Those are young patients, late relapse, and
वो तो मैं वाला repeat कर
and no comorbidities.
वो सही है, तो you took a clue from here. Next time criteria वो 4-5 है, उसके there is a criteria for BMT. I agree with you. कि इस सिचुएशन में BMT करना चाहिए, दिस इज कंटेस्टेबल, दिस इज ट्रू, बट ये कोई नहीं बोल सकता कि you don't have a CRs with BMT, you don't have some patients surviving long, and if you have to use it, then you have to know किस situation में करेंगे use. So बहुत बढ़िया. अब ये patient, they usually are long-term survivors.
Yes.
So what are the complications we'll be looking for in long-term survivors?
So the patient receives mainly cisplatin based regime and bleomycin etoposide. So there are complications with the form of pulmonary toxicity and skin toxicity, Raynaud phenomena, cardiovascular toxicities, metabolic syndrome, because patient receives cisplatin based chemotherapy, and chances of the infections and secondary malignancy within patient receive etoposide also, leukemia. Yeah.
कुछ numbers याद रखना इनका, it will be useful.
Yes, sir.
Dr. Amit, any question from your side?
Yeah, so I think, is there, like in other malignancies, is there any definition, or when you will call it as a cisplatin refractory, or when you will take it as a cisplatin sensitive? And the second question is whether early relapse is better or late relapse is better.
Sir, cisplatin refractory patient both progress within a 4 to 6 weeks.
Is there any as such that is
No, sir,
like
there is no any as such definition of cisplatin resistance.
So what we take in practice, if there is no definition, we have to take something in the practice now. For everything in clinical side, there is no, we might not a 100% clear answer, but for managing the patient, we have to decide something by ye kare, aisa, everyone is taking this, so we will take this. So suppose one patient's chemo completed, and now the paradoxically tumor marker started rising within 3 weeks. And another patient where the chemo completed, there is no residual scan in the tumor marker normalized, the response CT, no disease, and the tumor marker started rising after 4 months. So will your management in a relapse setting is different in this scenario?
Sir, no,
so as such, there is no clear-cut definition.
No,
But in day-to-day practice, what we take that if there is a paradoxically tumor marker started rising while patient on the chemotherapy or within 1 month of completion of the chemotherapy, then we more or less take patient as a cisplatin refractory patient.
Yes.
But if the tumor marker patient responded and then reappearance of the disease at some point of time, then we will take as a cisplatin sensitive, and then we re-challenge with the cisplatin. The other scenario which can be seen that the tumor marker has normalized and there is a paradoxical rise in the abdominal lymph node. What you will interpret it as this situation?
Sir, maybe chances of teratoma is high in this patient. So we can plan for biopsy for this patient.
Growing teratoma. So
Growing
the
teratoma, yes,
tumor
growing
marker has responded and the tumor marker. So then there is no benefit of going for chemotherapy in this scenario. You have to go for a surgery. So regarding what Dr. Kumar was asking, is there is sometimes the response of a second line chemotherapy, there is one score. If someone is doing very good, then the examiner may ask about
International prognostic function specific group, this is score, sir.
So what is that score name as?
Yes, IPFSG, this is score, sir.
So what are the criteria? So
Yes, sir, they include, sir, with the histology, with the seminoma, non-seminoma, location, gonadal, retroperitoneal, and the mediastinal. And after that, platinum-free interval, less than 3 months, more than 3 months, and the best response with CR
yes,
or
that is
negative, and
we can stratify. So where you place the autologous transplant in the schema of management of testicular
yes,
cancer?
those who are patient has a high risk, those score is more than 5, because their survival with after salvage is around 17%, 3-year overall survival.
No, so patient has relapsed after 6 months. So do you want to give second line salvage chemotherapy? Yes or no? Then if yes, then what type of chemotherapy, and where you will place transplant in this scenario? Second line, third line, the second relapse, third relapse?
Yes, sir. Patient is when relapse after 6 months, we can plan for the salvage treatment with cisplatin based, sir. If initially patient receive PEP, then we can plan for the VIP or
I am asking, you are not getting the question. Will you like to transplant, send the patient for autologous transplant in first relapse, or you want to give the salvage chemotherapy, see the response, and preserve the autologous BMT for third relapse, or you want to go the transplant in the first relapse?
In the first relapse, I want to go with the salvage conventional chemotherapy.
Salvage chemotherapy only. So I think this question is still a little bit controversial.
Yes,
Is there any study to answer this question?
the Tiger study, sir. Before TIP versus high-dose chemotherapy. Ongoing, sir.
So till the time nobody knows the right timing of the transplant, the Western world, the American school of thought that is to go for a transplant in first relapse, whereas the European school of thought, they still believe that second line salvage chemotherapy, because the trial which you are quoting, that was the 1994 trial, where the benefit of autologous transplant in first relapse was not very clear, and the caveat of that study, they have done only, they have not done the tandem transplant, which is the standard of care for in testicular cancer. So we still go ahead with the salvage chemotherapy and keep the transplant reserved for third relapse. But if one wants to go ahead, the retrospective data from the the Indianapolis University has shown that a second line first relapse also do benefit. But the final answer, the trial will provide whether TIP is better or a stem cell transplant is better in first. Till the time we are practicing the salvage chemotherapy and keep the transplant reserved for third line.
So for mediastinum GCT, we can go with the salvage treatment, or should we proceed with the high-dose?
So the management of mediastinal NSGCT relapse, if you see the scoring system, the worst score will be given irrespective of the tumor marker and all that.
Yes.
So whatever you do, whether you go for a salvage chemotherapy or you go for a transplant, the survival is not going to great. If you directly compare slight benefit with the autologous transplant, in day-to-day setting, if there is a mediastinal NSGCT which relapses after first line of chemotherapy, family very keen, we try to keep the transplant in the first relapse rather than keeping it for third, because we know that and even with the transplant, the results are not very great compared to the testicular. So we keep in second line rather than for a testicular, we may consider a second line chemotherapy, either VVIP or TIP. So if you want to use TIP in a second line setting, what is the ideal scenario and what are the dose for TIP in that scenario?
Sir, for the TIP used in that is A1, paclitaxel 200 milligram per meter square 24-hour infusion, ifosfamide 1.5 gram per meter square day to day 5, and cisplatin also 20 milligram per meter square day to day 5. But this is modified to paclitaxel 175 milligram per meter square over 3 hours. And IFOS 1.2 gram per meter square day 1 to day 5, and cisplatin 20 milligram per meter square day 1 to day 5.
Yes, so that is important, that the original TIP protocol which was used, and basically in those studies, cisplatin sensitive patients were taken.
Yes.
So more than 6 months relapse, no mediastinal tumor. So the survival for those group of the patient, 5-year survival reaches close to 45%, who has received the original TIP with the 250 mg per meter square 24-hour infusion. So in our day-to-day setting, the patient is very fit, can able to tolerate, there is no residual toxicity of previous chemotherapy. We can try to push those, because we know the transplant is most of the time is not possible in our scenario. So in those group of the patient who are platin sensitive, otherwise fit, we could push for the original TIP rather than the modified TIP. But definitely the toxicity is going to be the major deciding factor.
Yes.
So if any other question, comments, clarification by anyone? Go ahead.
This, if you have a DVT or an IVC thrombosis at the offset, does it change anything? Cisplatin, more of arterial thrombosis than venous, but does it change?
So Amit, the question is that if you have a DVT, does it change the treatment plan, especially versus cisplatin?
Since if the patient is having, we don't change, because this DVT mostly in a setting of a large abdominal mass is because of the pressure, the retrograde pressure into that. So we don't change the treatment. We continue. The most difficult question will come in two scenarios: if the patient have developed a pulmonary thromboembolism, or patient has a cortical vein thrombosis, or developed MI. So with first or cycle, which we have seen in few patients. So that is the most difficult scenario. Should we avoid cisplatin, knowing a complication? But I think in 1 or 2 patients, which I remember that with the anticoagulation and discussing the patient, because we know that the cisplatin is most important apart from the myocardial infarction. I think in patient with the pulmonary thromboembolism and in patient with the sagittal vein thrombosis, at least we continued with the cisplatin. For myocardial infarction, because of the associated other problem, we shifted to the carboplatin. But definitely, I don't have the answer for this. But for a lower limb DVT, definitely we continue with the cisplatin. We don't avoid cisplatin.
The cisplatin is the most important. So you try to find out ways and means to give it. Where you can't, then you change.